Hello, everyone. My name's Corey Silito, and I will be leading the Leadership Ground Rounds today. And we got a great session today. It's about RT roles outside of the four walls of the acute care hospital, unconventional post acute career paths that are taken. We have three great panelists today that will get great information from. And as you all know, discussion groups and break rooms are all often full of conversations about how limited RTs' career paths are. And many of those RTs believe that unless they want to go into management, teaching, or sales, bedside care is their only option. So the reality is that there is an ever growing number of career paths out there for those who know where to look or those who um, have blazed their own trail. We'll hear from these three RTs who have taken the roads less traveled by in respiratory care, sharing how they started their journeys, the ups and the downs of their paths, and lessons they've learned along that way. So each of their stories will put a new twist on some aspect of our profession and can help leaders inspire their teams to explore RT's valuable expertise outside of the hospital box. So the three panelists today, first one is Mike Hess. He's a senior director of advocacy and regulatory affairs for the COPD Foundation. Before joining the foundation, he had a unique role as a primary care RT, where he was occasionally described as a pocket pulmonologist, allowing the clinic to do an on-demand spirometry and improving care coordination. He is also currently the chair of the ARC ambulatory and post-acute care membership section. Second of all is Chrysalis Ashton. She has 12 years of experience as an RT. She started in the acute care, but found her passion in home care DME. She works at CareLink Medical Equipment and Supply in Michigan as a director of clinical operations. She's managing over 60 plus respiratory therapists and clinicians in that role. And last but not least, Amy Trees serves as the coordinator of community respiratory care at Mission Health Partners. It's a clinically integrated network and Medicare accountable care organization. Amy received the 2016 NC Phil Award in recognition of her work in pulmonary care. So to that end, I will begin. And we have some questions here that we can start off. And one of the questions is, why and how did you leave the four walls of the hospital? And Chrysalis, would you mind
Of
starting off with
course.
that?
Of course. Thank you, Corey. I'm excited to be here. So my story started in a NICU, actually. When I was a respiratory student, I thought that was my dream job. I received that dream job right out of school and lasted about 6 months before I decided that it was not for me. And I actually went through a period where I was afraid I wasn't capable of being a respiratory therapist if I couldn't handle our most precious patients. I came to my senses, decided not to waste the degree I had just worked so hard to earn, and happened to take a chance on a posting for a home care position. I didn't know anything about home care at the time, as most of us don't when we come out of respiratory school. But I'm so glad that I did because it's definitely where I found my home working in the post-acute space. And my main priority doing this role is keeping patients out of the acute care hospital.
Yes. Amy, do you mind telling us your story?
Sure. I similar to Chrysalis, I was in the inpatient acute care setting, and I loved NICU PICU team. In fact, I wasn't even looking to leave the hospital. The health system I worked with, it was also an affiliate cystic fibrosis center, and they to be an affiliate center, you had to have like an established team of people. It included doctor, nurse, social worker, dietitian, and then either a PT or an RT. And so the opportunity came along that said, hey, would somebody, anybody be interested to go across the street 1 day a week for CF Clinic Day? And I just said yes. It just sounded like a neat opportunity. And um, that turned into 2 days a week and then eventually turned into a 5 day a week pediatric pulmonology outpatient clinic. And so that's how it happened for me.
Incredible. Thank you. Mike, how about yourself?
Yeah, well, mine honestly was a little bit of self-interest. I was working at a relatively small hospital and kind of bored. And this was right about the time the hospital readmission reduction program had started, and one of the upcoming conditions that was covered by that was going to be COPD. And I saw that there really wasn't a lot of work being done in COPD, and there wasn't a lot of progress being made in helping people stay out of the hospital and reducing readmission. So that's why I was getting added to the program. And I thought, well, if I can become the COPD guy, then that's maybe how I can make my mark on the profession. And fast forward a couple of years, I was able to pitch a position to our local medical school, and as again, kind of that care coordination type of role, and been able to build a pretty decent career in the COPD space after that. So it's been a great journey, and I'm really excited to be able to contribute to moving things forward.
Oh, awesome. It's funny how we all kind of just go and start to help and so forth, and all of a sudden becomes our passion, and we move on and we go through it. And there is opportunities outside. I've joined a little bit of the DME myself, but and recognize the great things that are done outside of the hospitals as well too. So appreciate all that you guys are doing. So second question I have here is, what advice would you give RTs who are looking for something beyond the bedside care, but are not interested in management, education, or even sales? What kind of advice would you give them? Amy, how about you start us off?
Well, I would just think about like that show, Say Yes to the Dress. I would just say yes to opportunities, like regardless of what they are, just give it a go and just try it out. It doesn't hurt to just to try it out. That'd be the first thing. And the other thing I would suggest is just if there's something that is interesting, but it's not necessarily posted for a respiratory therapist, but you feel like it's something that would be a fit for you, I would go ahead and just apply, put yourself out there.
Thank you. Chrysalis, how about yourself?
I would say that my advice is to network. And so, as Amy said, if the position doesn't exist, try to get into the space that you want to be in, because sometimes those positions aren't posted, but they are available. In particular, if you look on Indeed and you type in respiratory therapist, you're going to find 300 acute care hospital jobs and maybe one home care one every now and again. But there are other roles out there. I would also give the advice to challenge traditional job postings that require a registered nurse if it seems like you fit all of the other boxes other than having that nursing license, because a lot of times we just aren't thought of as RTs for some of these roles. But good examples are like discharge planners, care coordinators. There isn't really a reason why a respiratory therapist can't do a lot of that same work. So challenge those norms and network and meet people and get out there and see what's actually out there.
Yes, incredible. Thanks. Mike, anything to add to that? Or
Yeah, so I had a fantastic piece of advice from a mentor who was one of the people behind these webinars. As a matter of fact, I don't want to call him out, but you can probably figure it out. He once said in a presentation that if you want to have an impact, you've got to find out what's keeping the C-suite up at night. You know, what's affecting your CEOs, your CFOs, your COOs, and because that's every challenge is an opportunity. So if you can figure out where those pain points are, where those pressures are, and come up with a plan to potentially alleviate some of that, then again, you can have a really big impact.
yes, there's a question in the chat there for us. And did you guys have a mentor or anyone to help guide you as you shifted your careers? Mike just said that he did, but does anyone on the panel also have a mentor? I'm sure you do, that helped you.
I did not have one until much more recently in my career. So transitioning from acute care to home care was more of just a leap of faith. But as I got into that space, I acquired mentors, in particular, an individual who helped me get into leadership, which is where I'm thriving at the moment. And then from there, being more active in the AARC and actually seeking out people in my space that I admire, I have acquired quite a few mentors, and they have been invaluable to me in advancing my career, building my confidence. I having a mentor is one of the most important things I think any individual can do in their career.
Yes, I totally agree. One quick question I had for all of you is I also tried to step outside and go outside the four walls, but I was really slow to do it. I left my leg in the hospital setting for a while as I walked. Did you guys do that, or did you just jump out and go for it?
I jumped all in into the deep end of the pool.
You all did, just jumped in for
Yeah,
it? You know?
very similarly. I got my position because I tracked down the dean of the medical school's email address and basically cold emailed him and said, "Here's what I think we should do. Here's why I think we should do it." And didn't really expect to ever hear anything back. This was right around Thanksgiving, especially. And fortunately, about an hour later, he emailed me back and said, "Well, it's going to depend a little bit on what's going on in the community, but let's take a look." And the rest is history.
Awesome.
I was a really slow leave. Like, I mentioned earlier, one day turned into 2 days. And then it was so slow that you can imagine that my coworkers in the respiratory department would be like, "Hey, you're holding up one of our FTEs, we're short because of you." And I would be like, "No, no, no, no. My time's being contracted and paid for. Like, please don't look at me that way." So it was that slow that people were like, "Push her out the door." And so when it finally turned into 5 days a week, everybody was ready for that. And then I found out that I was clocking in under the chaplaincy program for a long time. So I was even being paid for, not by respiratory, for a short time. So yeah,
Oh,
slow
wow.
leave.
Yeah, incredible. There is a question in the chat, and this is for Chrysalis. If given the reimbursement issues and limits for the RT services, how has this impacted your position and hiring expectations for the future?
Very good question. So unfortunately, the DME industry over the years has suffered in terms of respiratory services because, as most of us know, there is no reimbursement for respiratory services anywhere. Medicare doesn't recognize this as a true profession. It's unfortunate, but it is the reality. And so, yes, we are constantly in this space looking at ways to be more efficient. I am fortunate to work for a company that really values our respiratory therapists and our respiratory services. And we are able to kind of go outside of what the traditional reimbursed services are and add on things like having respiratory assessments through some other partnerships. However, I do believe that the tide may be starting to turn because of value-based healthcare, which is where everyone is shifting. So keeping patients out of the hospital, in particular COPD patients, is huge for hospital systems. So that's what's keeping the C-suite awake at night, as Mike mentioned, is how do we keep these patients from coming back within 30 days for the same condition, or we're going to be penalized.
Yep.
And home care, specifically respiratory therapists in the home care, are the answer, in my opinion, because we're all one healthcare team. So it is challenging. Reimbursement is constantly changing, and there's more change on the horizon. But healthcare in general will suffer with the loss of home care if we don't make it a priority.
I totally agree.
One thing I'd love to add on to that is this is why it's so important for every RT, regardless of what setting you're in, to be paying attention to legislative initiatives. For example, we have one of our key things right now is called the SOAR Act, the Supplemental Oxygen Access Reform Act, which aims to reverse some of those changes that Chrysalis mentioned, provide new career paths for RTs by, for example, actually mandating that RTs be able to provide oxygen equipment education in the home, and really expand those career paths. So, I know a lot of times you might be, because beginning of my career, this was me, you're the acute care RT and you're looking at, what's going on? Why do I care about how we pay for home oxygen, anything like that? It's really an investment in your future and the future of the profession.
Mhm. Yes. Amy, I had a question here for you. Have you found that you had the skill set from your acute care work to succeed in your current role? And if not, could you expand on what you've added to your knowledge and skill set as a result of your current role?
So my current role includes being a respiratory advocate to all ages. So, my background was pediatric, neonatal pediatric. And so expanding to all ages was a big learning curve for me in my current role. But having said that, I've been at the same healthcare institution for 31 years. And I feel like in each opportunity that I had along the way, it prepared me. So much so that I almost feel like it's taken a lifetime to be a good fit for where I'm at. And I know that's another way of saying I'm seasoned, but to be honest, it's taken a minute to kind of be able to feel comfortable in a care management role. Um, so I would thank every person that came my way and every opportunity along the way that helped prepare me for this one. Even the physician and the provider engagement, the working together with other disciplines, the being able to connect with families, and along the way, it definitely prepared me for where I am now.
Awesome. Thank you
And
so much.
if I could add to that real quick, Corey, in home care in particular, unfortunately, there's a stigma that this is easy work and that we're not real respiratory therapists. And if you know me at all, you know I am rail against that with all my might. But what I actually, as a hiring manager, I have found is that we don't want to hire brand new students because they don't have that skill set quite yet. They don't have the confidence. They aren't ready to work independently or autonomously. And so I don't usually hire students. I like to see a few years of experience under their belt in an acute care setting because those skills absolutely translate. You may not be doing CPR every day, but you absolutely have to manage mechanical ventilators and other respiratory equipment that if you don't have that core knowledge from that space, you're not going to succeed. The other piece of home care that it comes to as a surprise to a lot of the RTs that I hire is that we are the experts, the clinical experts in our world, and we don't necessarily have a doctor telling us what to do all the time. We always have to have doctor's orders, but we are usually the ones recommending what the patient needs to the doctor, and they are agreeing and signing on whatever we need because they trust us. We are the ones that know those patients best. So absolutely need that skill set to be in home care.
And I think in addition to that, I saw a question pop up from the audience, so it's a little bit out of sequence, but the question was having a bachelor or master's degree required for these positions? And if I would argue, I'm not a hiring manager, so I would defer to Chrysalis on this, but I would say that if they're not, they should be, because I learned so much from my bachelor's program. This was before I took on my primary care role, and then learned even more in my master's public health program. And ironically, it's the things that most people describe as like blow off classes or things like that. I mean, I had an interpersonal communication course. I had a lot of contextual things like that. I had a Buddhism course that actually taught me a lot about negotiation and trying to find the middle way and the win-win for people. That then I was able to apply in my then acute care role, but then also that transferred into you'd be surprised maybe how much it would transfer into tobacco cessation treatment. Trying to negotiate with somebody, well, maybe you can't outright quit, but can we cut back a little bit? Finding out what motivates people. Those are the soft skills that unfortunately there just isn't time to teach in the base RT program, and are really helpful in these quote unquote non-traditional roles.
Yes. Thank you. Here's a question for all of you, and I'll start with Amy. What resources provided by the AARC helped you to succeed? And what additional resources might you be useful for those following in your footsteps now?
The AARC, when I started the role I'm in now, I reached out to them. That's who I turned to. I just called, and whoever answered the phone was the lucky person that heard this timid little voice saying, I need a mentor. Here's what I'm doing. Is there anybody that you can connect me with? And they immediately emailed 3 names, one of whom was Mike Hess. I'll be forever grateful that because he's my mentor. And I don't know if you consider that, but I'll always consider that the way it is. And then to go one step further, the subgroups that we have at the AARC, we have the ambulatory post-acute care group. Now we mentor each other. And so that's been a fantastic resource to tap into. Even yesterday, we talked about another way the AARC would really help us is it's hard to know who's who. Like I know that I know my role, but boy, it'd be nice to have a buddy if I knew of somebody else in the AARC that was kind of doing what I am in an accountable care organization. We would really be able to talk at a deeper level and to brainstorm together in a great way. So I've really benefited previously from AARC help. I'm currently benefiting from AARC help through the ambulatory section, and I'm looking forward to new ways that the AARC can help.
Yes, thank you. Chrysalis or Mike, anything to add to that? Or-
Yeah, absolutely. I got involved with ARC a little bit later, not really at the beginning of my home care career, but over the last few years, I will say that just a little shout out to the Emerging Leaders Program. I still think that is the best thing that the ARC has ever done. I was the one of the first graduates of that, and you are assigned a mentor who I absolutely connected and I'm so grateful to my mentor who I know is listening right now. So thank you. You know who you are. And also connecting me to other emerging leaders, other RTs that are kind of forging their own paths and wanting to go above and beyond and just do more with their career. So the networking that the AARC makes available to us through the section groups, through the AARC messaging board system, through conferences, has been a huge resource. I also rely pretty heavily on the AARC for clinical practice guidelines because that does guide what policies and procedures I create for the company I work for. So I agree that that's a very good resource as well.
Yeah, I'll throw another vote behind networking at every level. I mean, going to your state affiliate and any kind of meetings and conferences that they have, all the way through up AARC Connect. Sometimes it waxes and wanes a bit, but one of the best things I found on AARC Connect was the Leadership Book Club. Unfortunately, I haven't had time the last couple of years
Yes.
to really get involved in that, but learning and actually having to set aside time to actually read the book that you want to read. But then the discussions that follow on from that are just fantastic. So definitely find any of those maybe less obvious ways to do networking or to build those bonds, and great platforms for that all around.
Yes, there's a ton of information. I love all those groups and even the book club. I did get to join it this last time, but I've been into the other ones, and so it's been great. I appreciate that. So here's another question, and this will be for all of you. Do you believe that the compact licensure will help expand opportunities outside the acute care setting for the RTs?
I'll jump in with a
Okay.
yes, because early on in the pandemic, sometimes being a trailblazer can be a blessing and a curse because you get to make your own path, but then when things go awry, there's not really a model for what to do next. So I was really cruising along in my primary care gig. I'd been there for a few years at that point, and then 2020 hit. And they had no idea what to do with this guy who is now sitting, in the office, or can't bring any patients in because they're all riding the bus. We don't want to expose people and all that kind of stuff. So they had no idea what to do with me. I was scanning forehead temps, and I was putting on the bunny suit and doing nasal swabs. They couldn't send me into the hospital because of all kinds, the credentialing and privileging and stuff like that. So it was just, I was kind of stuck in this limbo. I just lost my train of thought. Blessing and a curse. What was the question again? I'm sorry.
Oh, no problem. Let me try and find that.
Compact licensure.
Compact
Yes,
licensure.
compact
Yes, thank you.
licensure.
Okay.
I'm trying to scroll down and trying to find it. Sorry.
I really was going somewhere with this. So one of the things I was curious about was, this is also, the pandemic also kind of threw telehealth and remote monitoring and all that kind of stuff front and center with everybody. And so I was able to get to, kind of a part-time side gig as in a remote patient monitoring program, where you had to look at their statistics and make some contacts and things like that to comply with the program requirements. But it was in Virginia. And so I actually had to go fortunately it was pretty easy, I had to get a Virginia license being based in Michigan. in that particular case, it wasn't particularly a big lift, but having a compact licensure where you can just, do kind of some pro forma stuff and really have some opportunities to do remote monitoring across those state borders. I think certainly that's simply one example of it, but I think it's definitely going to be helpful.
Yeah,
Awesome.
I would agree with that. In home care, when I'm looking at hiring, having multiple state licenses is a huge benefit. So the ability to just have a license where you're able to practice in all of the states that our companies operate in absolutely will expand those roles for RTs.
Yes, agree. Um,
Absolutely for me too. I'm hardly patient facing, so I'm predominantly telehealth or on the phone even now. And I can only see it opening up so many more opportunities just outside of North Carolina if there were compact licensure.
mm, Thank you, everyone. This is a great question on the chat by Mike O'Brien, and he says, how does respiratory therapy education need to change to prepare therapists for the non-traditional roles? What are you guys' thoughts on that?
I can get on my soapbox for a moment. In home care in particular, that's my world. We need to spend more time on it. And I understand that there are so many guidelines and the ICUs, the NICUs, the PICUs are our primary focus. But I've been doing my best in my local communities to work with partners or local colleges and forming partnerships with them to make sure that we have students coming through. I also volunteer to teach labs and lectures in their programs. So giving those non-traditional RTs an opportunity to come into your program. And even if it is just, I've also done recorded lectures for programs where I can't be there physically in person, just giving them that exposure, letting them meet or hear from somebody that's actually doing it, I think is huge. And I know, again, stigma around home care is I got to do it for one day maybe, and I just sat there, or I did, check somebody's pulse ox and moved on. That's not home care. That's unfortunate. It's just like your hospital. You go in there for one day and you could just have 10 treatments that day and nothing else. You go the next day and you have 4 codes and an ICU admit and 65 ABGs to draw. It's very similar. So that little snapshot during those rotations is not always enough. But being able to speak to somebody, I've been told I'm pretty passionate about what I do, and I think more people like me need to get out into these colleges to make themselves known, because I've had several RTs that have come into home care saying, you were the reason because you were so excited about it. And, I was exposed to that through that excitement that I wanted to give it a try myself. So even if it's just a lecture or a lab, I'm trying to tiptoe my way into these programs. But for the educators out there, reach out to local DMEs or pulmonology offices or those other areas where RTs work, and allow them to come in and just spend some time with your students.
Yes.
Yeah, to that, I might add, we tend to be, from what I recall of my RT education back in the day, it's very technical because it has to be. I mean, you have to know, how ventilators work and the procedures for drawing an ABG, or you have to do all of those things. But I really think where we have the opportunity to add value is learning, again, some of the softer skills and some of the administrative / organizational skills. Like, for example, when I got my bachelor's degree, it was a program called Interdisciplinary Health Services. And it also taught about how the healthcare system works, at the different levels, and, how private practices work and things like that. And it really gave a lot of additional perspective and made it easier to try and look at that bigger picture and see where RTs currently fit in, where we might fit in, and how we get there.
I have two suggestions that one is a little bit of a soapbox, and that is I really think it would be valuable for education to begin to include whole person care with RT education. In my career, I spent 100% of my time focused on, what was ordered, getting the treatment done, making sure the medication was right, the delivery device was working. And I spent that amount of time really focused 100% on that. And now I'm learning that, there's a whole rest of a person. In fact, lots of other things inhibit a person being able to be compliant. And I think it would go a long way if we taught our students how to listen. It was a long time before I ever even heard of motivational interviewing. But outside of the walls of the hospital, it's a different beast. We're in it for the long game, and we have compliance issues because COPD isn't going away and asthma controls every day. And so we have to really understand the tools of how to engage in the long game and how to really identify with a patient on compliance with medications and why it's valuable also from their perspective. I just can't imagine now when I think about social determinants of health, asking about an inhaler without asking about, do you have transportation to the medical appointment? Or do you have enough food to eat? Or is your environment safe that you live in? I just think the whole person concept would be extremely valuable for our students upcoming.
And that really helps, especially in the foreseeable future, that helps the acute care therapist as well, because that might be the only person who ever teaches somebody how to use their inhaler, whether it's in the ER or, whether it's, in an inpatient room, and it's not the ideal setting for that. But so many people never get any instruction or evaluation on whether they can coordinate an MDI or whether they have enough peak inspiratory flow for a DPI. So, even the acute care therapist who isn't looking at this particular career path right now, that's truly where they can have a huge impact, because they might be the only person doing that.
Yeah, I totally agree. And Amy, I really like what you had said, the whole person care. You're absolutely right. There's more to the person than their lungs, so to speak. And so I appreciate that. And where I work, we have pulmonary disease navigators, and they're just involved with the respiratory aspect. But you're right, transportation, finances, and everything becomes so valuable as that person in that role. So those are great. This next question may be directed to you. At first, Mike, it says, what are your thoughts on providing COPD education to online COPD groups?
I guess in general, I'm in favor of it. It's
No kidding.
it's technically where I actually got my feet wet in COPD. I started a Facebook group back in the day that it was an opportunity. My dad was a teacher, and he was very interested in learning styles, and this was back when Facebook wasn't quite what Facebook is today. And it was a great opportunity to have asynchronous communication, or you could have text, you could have videos, you could have pictures, you could do hit all these different kinds of learning styles, and really have those opportunities. Being able to provide, even today, even being able to provide education online is really beneficial to a lot of people, because they may not have access to a COPD educator or an RT or any kind of specialist in their particular area. They might even be in a pulmonology desert where it's 2 hours to the nearest pulmonologist that they might be able to see every 6 months or something like that. So, really, we have all of this technology and all of these tools. There are some very positive ways that we can use that to help people better manage themselves, or, to help family members or caregivers manage the people that they're caring for.
Yes. Well, thank you for that. Another question here is, Chrysalis, how do you handle thoughts or comments sometimes about people saying, you're going to lose your skills if you leave the hospital, or that you aren't now a real RT if you leave the bedside? How do you handle
I
thoughts and comments?
I tell them to come spend a week with me, and they will
Yeah, I
change their
bet.
mind very quickly. No, I hear that a lot, and I unfortunately get applications from RTs who come to the interview and tell me they want an easier job, and I have to unfortunately tell them what the job is and how difficult it actually can be. And although, like I mentioned before, you're not doing, I like to say in my space, the emergencies are different. We're not running to codes, but we still have urgency. We still have patients that need to be taken care of. We still have schedules that we need to manage. We have staffing issues that we need to work through. So there are a lot of similarities. And truthfully, come spend a day with us, and you'll see the amount of skill it takes to do this, the amount of independence it takes to do this. And so I just kind of live by example, or lead by example. Like, watch me watch me, what I'm doing, and this is home care. This is what we do. And I also will say, your career is what you make it. So if you go work in an acute care hospital and you're comfortable just doing treatments for your career and that's the kind of RT that you want to be, that's great. In an acute care hospital, you could do a lot more. It's the same with home care. You come into home care and you can just be, your average RT doing the things that need to be done and not much more. You're still going to be busy, but it's what you make of it. There's so much more that we can do for our patients. We have a lot more freedom in home care than we do in acute care hospitals and autonomy. And if you want to use your skill and actually put those skills into a different category and different use, then come work for me. Come work in home care.
Yes, thank you. Any other thoughts from either panelist?
I think again, some of it is that technical sort of bias that we have, where we have these career paths and we have these very defined things. But I mean, a lot of times I'm a little reluctant to do this, but a lot of times people will say, "Well, look at nursing." And I mean, do you say a community health nurse, is that not a real nurse? Is a nurse working in a physician office, is that not a real nurse compared to somebody working in the hospital in an ER or an ICU? It's simply a different kind of practice, and the more we can bring RT perspectives to different venues and different settings, the easier it's going to be to actually demonstrate the importance of our roles. That was something I was hoping to achieve in primary care, especially working at a medical school, trying to get these new doctors to get used to having an RT, so that when they go out into the real world, they say, "Hey, we need to find ourselves some RTs because we had one and he did a good job." So I am never one to say that's not a real RT. It's simply a different kind.
Yes, I totally agree with that. Another question here. What current barriers do you face in your non-traditional role, right now? Amy, can you think of anything? Obviously you're in there's different barriers in each roles that you do. You think of anything in yours?
My current barrier is change.
Yeah.
I and anything that's going really great and really good, it's fluidic, and so the barrier is staying, like Mike was saying, or maybe Chrysalis, somebody was referring to value-based care, like trying to stay a little bit ahead to be able to pivot easily. And so I just that is my barrier, is um, to know that these are unique opportunities, and with unique opportunities, they quickly fluctuate, and so we have to be ready to pivot in another positive way.
Yes, I think the only constant nowadays is change.
And that kind of goes back to what we were talking about, real therapists, and what Chrysalis was saying, that if you go to Indeed and you look for a respiratory therapist, you're going to find 300 openings for an inpatient therapist. And so that it's a battle to think, okay, I have lost that skill set, and I have to just kind of take captive my thought. I have a new set of skill sets that I use. How do I find those opportunities? That's a barrier, is my own head space.
Right. There's a comment somebody wanted to just share with the panelists here, and about the topics we've been talking about. It said acute inpatient rehab is an excellent place to gain perspective on how other disciplines run, and to grasp the concept of seeing the big picture, of a patient from admission through discharge, along with learning about how discharge dispositions affect the payments and so forth. And there's also a potential, stating, to slide into admissions liaison position or transition to quality roles, among other things. And this is similar in an LTAC environment as well, too. I've seen many respiratory therapists that currently right now, we were in one version of a computerized charting system, and we moved to another one. But who helped guide us through those changes and made those changes? It was two RTs that years ago had moved over to that IT world, and helped us. And it's so incredible that they were able to get us further than we were able to go with the other organizations. So for that, I appreciate that. So
Absolutely.
another question here. Have your perceptions of respiratory care changed since leaving the bedside, Chrysalis?
They have. And I think it goes back to what Amy was talking about, the whole person, because when you're in the hospital, you're really focused on fixing the patient up, getting them to the step down, to the floors, to out. We we have a very specific goal in mind when we're working in the hospital. When they come home or when they go through a clinic or whatever the case may be, or they're looking for COPD education, there's a lot more factors involved. And things like transportation. Do they have enough food in their home? Do they have childcare? How are they going to get to and from work? Is the equipment there's so many other pieces to this. And if we get stuck in our pigeonhole of we are only responsible for the diaphragm up, which I still use that sometimes, we forget about the rest of the human. And I think that has home care has definitely changed my perspective on that. And it also has opened my eyes to some other things that we learn in home care that are not taught in respiratory school, like enteral nutrition and urology systems and what have you. So yes, I would say the answer to that is yes, it has changed my perspective, I think for the better.
Mm, thank you.
Yeah, similarly, I would say that I have always felt that we have an essential profession, regardless of what setting we're in. And being outside of going outside the hospital has really just has amplified exactly how critical that is. And we have very unique set of skills and knowledge and experiences that really a lot of the healthcare system is missing out on because we haven't been able to experience those roles. So similarly, I would say it has changed, but it's gotten bigger.
Yes, certainly. Been a lot of comments on education, and we touched on that, bachelor's degrees and master's degrees within the health profession, but also business as well too. Do you think that would be a good opportunity to look into as well? Business and administration, health administration for us. One comment here was really good. Susan had stated that they have a bachelor's RC program that has a course named Respiratory Care in Alternative Sites. Whoops, got my phone going. Sorry. Uh, and they said they could have never covered all the information in an associate's program. So RTs working at those non-acute care sites are interviewed. They provide the information to the students, and it's been a great. Sounds like it's a great rotation for them. So looking outside the box and looking outside the hospitals, I like that idea, and kind of basically agree with all the speakers that you guys have been doing speeches you've done today. So one other question here. What are you doing right now to prepare yourself for the next promotion or jump? Or you,
Staying involved.
yes,
That's my goal is to keep a finger on the pulse of everything that's going on in the respiratory world and the DME world because I found my focus. That's another recommendation that I got from my mentor was to tailor your career around your life's personal mission statement and let go of everything else that doesn't fit into that mission statement. So staying focused is what I'm trying to do and keeping myself available and involved. I try to stay active on social media so that more people see me and also home care and the fun parts of that and also reading. Lots and lots of reading.
yes.
Also learned that from a lovely mentor who I'm sure we all know.
Yeah, in fact, that was one of the questions in there. What books are you guys currently reading now, or if there's anything that you're doing now, just like I said, take that next step there. But I appreciate those comments. The another question I have here is, um, have you guys yourselves, do you have so are you supporting someone? Are you mentoring for someone right now? Can you speak to that a little bit, all
I
of you?
can. Sorry, I get excited about this topic.
Uh-huh.
Yes, I have several RTs that I have been mentoring over the last few years. And and when I tell you that this is like a full circle moment for me, holy moly. Uh, I got to see one of my mentees present at his first conference just a couple weeks ago, and my heart almost exploded. I was so proud, and And there are other things that I've been encouraging him to do. He's going back and getting his bachelor's degree because I encourage that. He's been promoted into leadership. That is really where that is for me, like where my passion is for me in leadership in particular, is getting to take the success and the skills I've learned and the mentorship that I've received and pay that forward to somebody else. And so, yes, and I plan to continue to do that and continue to mentor as many up and coming RTs and leaders as I can.
Yeah, absolutely. Paying it forward is so essential. I mean, I've had so many great mentors and sponsors and champions and everybody else in my career that I feel I don't want to use the word obligation because it's really a pleasure to be able to do that, but I really feel that it's important to continue pushing that forward and also trying to find that opportunity where maybe if I'm not the mentor somebody needs, I may know somebody who has the connection or has the insight or the experience that particular person is looking for. So one of the things I absolutely love to do is make those connections and build those networks. Even if I never participate again, that's not the important thing. It's that you're driving the mission forward.
My mentorship is just a little different because I'm on a small multidisciplinary team. I'm the only RT. There's a few nurses, one social worker, several paramedics, a pharmacist. You kind of get the drift. We mentor each other. And so there's some mentorship going on amongst us as a team. But even what I really value the most is the mentorship that's happens in the setting, this out of the four walls setting. I have a bulk of patients that are attributed to me. They're always mine. So it's not like in the hospital, somebody comes in for a few days and then they're gone. I'm in year 4 with this job. And so the mentorship is with the patient and the family. And so much so that, I can call. In fact, just a few days ago, I touched base with a family just to say, how's the asthma going? How's your child's asthma? And she goes, great. You helped us 3 years ago. We're on our way to our specialist appointment right now. He's doing great. It's a mentorship that's ongoing with this same group of patients. And I just want to highlight that because that's another neat thing that happens outside of our four walls. And Crystal can probably attest to that because in home care, you keep your people too.
Yep.
And it's a beautiful thing to have this ongoing relationship with our patients that we try to help.
That was something that really surprised me about my journey outside the hospital was, when I first started, it was like, well, okay, I'm going to get in, I'm going to do my patient ventilator assessment, interaction assessment. And I'm going to get out and I'm going to leave all the touchy feely stuff to the nurse because, that's their gig. And I'm not super into that right now. But the older I got and the more experienced, the more seasoned I got, the more of those things were really important. And now, I've been with the foundation for almost 5 years now, and I still keep in touch with a few of the people that I saw in primary care. I got invited to one of them had a 70th birthday party last year, and big bash with family and stuff, and we got invited to that. My wife and I got invited to that because you build those bonds over time. And it's been funny to kind of look back and see where I was at the beginning of my career with that sort of thing and where it is now.
I have the same thing in home care. We get invited to weddings, funerals, birthday parties, graduations, bar mitzvahs, like you name it. We really actually become part of the family, and we've even been called out in obituaries sometimes, individual RTs, because we've created those relationships. And like Amy mentioned, you start out with them and it might be years. It might be years of service and support that these patients need, and we're here for it.
Yes, so I have another question from someone in the chat there. Can you share a favorite patient story in your unconventional roles? Each one of you have one. Think of one.
Oh boy.
Yeah, actually, it's the person who invited me to their birthday party. Her name is Judy. And she'd been around the block a time or two, as you can imagine. She'd come to me, and I was yet another person trying to tell her how to manage her breathing and all this kind of stuff. And she was one of those people who, whenever she got short of breath, she would hit her albuterol, and she would go for the albuterol all the time. And I talked to her for a while. I said, well, albuterol works really well, but it only does one thing, and blah 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 blah. Look at why you're being short of breath. Maybe try pursed lip breathing and do all this stuff. And so we were meeting monthly for a while. I'd seen her for probably about 6 months, and she came in and she was like extra cranky that particular day. And she sits there and she's got her arms crossed and she's got, I got a bone to pick with you. And I was like, oh boy, here we go. And I said, what's that? And she said, well, you're in my head. I said, what do you mean? And she said, well, I was at home and I was short of breath, and I picked up my inhaler and I was going to take it. And all I could hear was your voice in your head saying, do your pursed lip breathing, do your pursed lip breathing, do your pursed lip breathing. And so I did it, and it worked. And so I'm mad. You need to get out of my head. And that was like, that cracked the whole ice. I mean, we were like fast friends beyond that. And it's been fantastic.
Great story. Thank you.
I have a lot of stories. I think one of the ones that sticks with me a lot is when I was still somewhat new to home care. One of my favorite patient types that we take at our company is pediatric. So they're coming out of NICUs or PICUs, typically on some sort of mechanical ventilation with a tracheostomy. And this was a family. It was their, I think, second child, and they were super nervous and scared. And our process is that we meet the family at the home with when the child comes home for the first time, and that's quite an experience, just being there for them. And usually you're the only one there other than other family. And so this one in particular, this house was out in the middle of nowhere, and I drove out there. I was probably there for an hour waiting for them. I got in the house with them. I was sitting on the floor playing with the baby, and they were going through their supplies. We were talking about equipment. They had some concerns and some questions. I helped them suction, and I spent a good couple of hours with this family. And it was heartwarming. And then, of course, that's my patient. So I would visit them every month, and we would go through their supplies again, and I would make sure to check their equipment. And then the best part of the story is a few years later, I got to go back to that home and pick everything up. And so the child had weaned off the ventilator. He had been decannulated. He didn't need his food pump anymore. So all of that equipment got to leave the house. And just the joy on that family's face and that relief of, oh my gosh, these last few years have been so tough, but look at our healthy, happy child. And being a part of that journey, we have that a lot in home care, and that really sticks with me.
Yes, incredible. Thank you.
I have a story about a gentleman who's in his 50s, and he loved to sing. In fact, his family was part of a kind of a famous bluegrass band, and he played fiddle, he played mandolin, he sang his heart out. That was his world. And he took a fall and broke his wrist. And so that was the reason that the nurse was calling him. There was also some behavioral health, some depression, anxiety, things like that. I'm saying all that to say the asthma was way down the list. But the nurse on the phone just happened to notice he was a little short of breath. But literally, asthma wasn't on the radar. But she said, hey, will you just call and check in anyway? And with the skill set that we've talked about of what we take from the inpatient and bring it outside of the walls, being able to do lung function and do it well goes a long way. And when we get to do lung function in the home, it's a win-win because we take away the white coat feeling, and it's a comfortable setting. And so he agreed to a home visit, and the lung function was done. It was so bad. His asthma was so uncontrolled. But again, it wasn't on anybody's radar because there were so many other things. Mainly, he wasn't able to sing and enjoy doing the things he loved. And so that's just like a no-brainer in our world, because that's what we're thinking. If you have good breath control, guess who gets to sing again? And so we think along those lines. We pre and a post was done, and It was so obvious, little bitty loop, great big loop. So there was so much potential for improvement. And the primary care provider, the internist, was open to suggestions, like Chrysalis had said. And so basically, that person was open to suggestions and was agreeable to asthma guidelines of controller, combination therapy, and then the next task was getting the patient to take it regularly. And so he was agreeable to kind of weekly visits from one of our community paramedics who also played guitar. And so they enjoyed each other pretty much once a week for about a month. And and as a result, the mood started to lift. He was open to it, like a social worker you know, like a social worker consult that got him pulled back into therapy. I'm telling you this because lots of good things are happening at the same time. And anyway, his lung function ended up being normal. And he was agreeable. I wanted to video him playing. He was able to start playing again with his family in a bluegrass band, and they were playing at the Western North Carolina, fair. And he was agreeable and signed the consent that I could come video him and share with my team who he was, because it was a really neat success story. And what was so meaningful to me was that I got to see and hear him singing with great breath control and smiling and enjoying himself, all while knowing his asthma was controlled. On the back end, was able to help get him a dehumidifier for his home, all of the things that are trigger reduction items that really benefits our pulmonary patients. So there was so many good things all the way around with that story. He's not my patient anymore, and so I felt comfortable calling him and asking him that if said person was interested in learning how to play the violin or the fiddle, could they recommend, a good one and that sort of thing. And so I ended up buying one of his old fiddles. And I've
Oh,
been
wow.
taking violin lessons now for about almost 10 months. I still sound like a third grader, but he inspired me. And so thanks for letting me share that story.
Yeah, that's incredible. All of you've had incredible experiences with your patients and they do become like family. And this time has just flown by for us. So we only got a couple of minutes left. So I want to thank all three of you for your time and your expertise in sharing those thoughts that and things that you've done. I truly, truly appreciate, and I think everyone that's listening today, you're all superstars, and you've done really enjoyable and creative things, and I appreciate that. As we leave this meeting, I just wanted to prepare for the next meeting and let everyone know that on our next LGR presentation is on November 20th. And it's from collaboration to impact, closing that gap between industry and patient care. And I also do have to mention one other thing, though. We had technical difficulties on our last month's leadership rounding. So they're re-recording that, and then that'll be posted, and then they'll put that in the library, the LGR library for everyone. But to you three, I say thank you so much, and I hope the rest of your week goes well for you and everyone else too. So thank
Thank
you
you.
so
It was
much.
an honor.
Thank you.
Thanks for having
Thanks
us.
so much.
Hi, everyone. We'll work on getting as everyone leaves, and then we'll have a quick wrap-up session, okay?
Okay, that's good.
almost done here.
Thanks for your patience with me, guys. I don't do this often.
I'm trying to help you, Corey. It's all good.
I appreciate you guys kind of help me get through all that. And you all are terrific. I truly appreciate it. It made it easier for me, for you guys to answer those questions and your professionalism and stuff. I truly appreciate it. So thank you.
Oh, it's my pleasure.
Great.
Yeah, y'all did a phenomenal job. I think that's the most questions, commentary we've ever had.
They
So
just kept coming.
yeah,
boy.
that was great. That was great. Well,
Thanks for having us.
yes, thank y'all so much for doing this. I think that Liz will probably have this up within about a week. I've actually, as I was listening to your presentation, we have an alternative respiratory care course here at the university, and I shared with my faculty, I said, listen, our class, they need to listen to this. This is going to
Yeah.
be great. And so thank you very much.
As Amy alluded to, we had our section meeting yesterday, and we were talking about how we really need to work with the other sections on letting you all know we're here and what we can provide, and these different career paths, so that educators can prepare students and leaders can help us fight for these positions and everything else. So we appreciate any opportunity. Well, I don't mean to speak for Chrysalis and Amy, but on behalf of the section, certainly appreciate the opportunity to help us spread the message.
Absolutely. Well, not only did you have a lot of people come, but you had a lot of people stay, and that's always a good thing. And
Yeah.
a lot of people engaged, and I had a couple of folks message me on the side. So
No.
Neat.
congratulations and thank you all for sharing. Bali, did you have anything? Liz, anything?
Nope. I think I'm good.
All right. Well, we're going to have this recording this time, so we should be
Yeah.
good to go. And listen, I hope everyone has a wonderful respiratory care week next
Yes.
week.
Thank
And
you.
Same.
thank y'all so much.
Thank you.
Thanks.
Thanks, guys.
Bye.
Take care.
You
Bye.
too.
Y'all have a great one.